5 years ago, I was in my first year of residency and caring for a patient who could have been my dad. He had attended the same college as my parents, at the same time, and he reminded me a lot of them. The man came in for what should have been a simple bypass, but something happened during the procedure. He had a stroke that left him in a coma with significant neurological damage. I was devastated and struggling to make sense of the situation. My attending mumbled something about the surgery resident reading the wrong patient's chart, delaying the procedure, and heightening the risk for bleeding and stroke. "Are we going to tell his wife about that?" I asked. "Don't we have an obligation to disclose medical errors?" "It's not a medical error," he replied. "Stroke is a known risk of bypass. It's even written into the consent form." I wanted to challenge him, but I realized that I was unsure of what a medical error actually was. What made something an error? What if no one is harmed? Is it still an error? What if someone is harmed, but it was an innocent mistake? What if the error was not really preventable? What's the difference between an error during a procedure, such as accidentally cutting the wrong thing, and an error in communication, such as accidentally reading the wrong chart? Do both count as medical errors? And finally, what if I prescribe the wrong medication, or make a misdiagnosis as a result of, say, an erroneous reading of an imaging test by a colleague? Would the error be mine? As it turns out, figuring what counts as a medical error can be tricky. One study found that 30% of residents and 50% of faculty knew what incidents to report. And, unfortunately, you will encounter medical errors. Up to 75% of residents have witnessed a medical error, and 45% have made one during their residency. So, understanding what counts as an error is important. Interestingly, there is still an active debate on this issue, but there are 5 areas of emerging consensus. 1. A medical error is something that is preventable. Preventable usually refers to a failure to follow accepted practice. 2. A medical error is outcome independent. When no harm is done, some people call these cases near misses. I once had a patient who had the wrong end of a stoma pulled up during a bowel resection for cancer. It was noted and corrected, but in doing so, we actually found a Meckel's diverticulum. So in a paradoxical way, the error helped the patient, but it was still an error. A colleague of mine once described a near miss that similarly turned out well, adding, "I was worried I made a medical error, but it turned out I was brilliant." Nice try, but still an error. 3. Not everything that results in harm is a medical error. There are risks, complications, and adverse events associated with procedures, and these are not necessarily errors. As a resident, I witnessed a healthy 40-year-old code unexpectedly during a surgical procedure. All of us on the team felt as if we did something wrong, but in reality, something went wrong. The unexpected happened, but there had been no error. 4. There are errors of choice or decision, inappropriate treatment choice, inappropriate delay in treatment, reading the wrong CT, or misreading it, for example. And there are errors in execution, like leaving a sponge in a patient during surgery, or writing the wrong dosage on a prescription. Both types count. And 5. There is a range of minor to major errors, from failing to wash hands to replacing the wrong hip. Considering these points will help you think through whether an error has occurred. As an additional resource, risk management staff can be particularly helpful in talking through scenarios when you are uncertain whether an error occurred. There's a common misconception in healthcare that medical errors are mostly a concern for procedural specialties such as surgery. However, surgery and high-risk procedures are not where most errors occur. Did you know that the cause of many medical errors has to do with teamwork and communication mistakes? Helen Haskell's 15-year-old son, Louis Blackman, died after a minimally invasive surgery. Louis didn't die from an error during the procedure itself, but from the weekend spent in the hospital after the surgery. You see, Lewis was receiving a drug at full adult dose, but no one realized that Lewis was becoming significantly dehydrated. He was not producing urine, but no one noticed he had gone a whopping 20 hours without urine output. Everyone was too busy and scattered. After all, it was the weekend. Lewis needed to have his IV fluid increased, but even after this was noticed, it then took days to get the orders changed. By then, it was too late. His status plummeted and he suffered a cardiac arrest, which his mother describes as being met with a delayed and chaotic response. Lewis's mother said that she has spent months and years pondering the circumstances that took her son from robust health to death in just 4 days. Her answer is fragmentation and unresponsiveness of the system. The lesson here is that errors aren't just about slips of knives or miswritten prescriptions. They are also about errors of omission, lack of communication, teamwork, and failure to take responsibility. All of us on the medical team have to be vigilant, understanding, recognizing, and preventing medical errors. Some have called medical errors a forgotten public health problem, since they are the third leading cause of death in the U.S. after heart disease and cancer. Let me say that again. Medical errors are the third leading cause of deaths in the U.S. And many errors are about failure of communication, teamwork, and vigilance. But even in our vigilance, we may have a particular blind spot when it comes to our own errors. There is a psychological term for this, bias blind spot. There are a whole host of cognitive biases in judgment and decision-making that we fall prey to without even knowing it. Anchoring bias causes us to rely too heavily on the first bit of information we encounter. Confirmation bias may lead us to seek confirmation of what we believe is true rather than to consider alternatives. Availability bias may cause us to focus on the most recent or vivid cases in memory and act based on those. These biases have been linked to diagnostic and management errors. In fact, diagnostic and management errors related to cognitive biases have been observed in 50 to 80% of trainees in real practice. This is compounded by the overconfidence bias, where people believe that they are less likely than their peers to make errors. This makes us more susceptible to failing to notice our own errors. I'll never forget the first time I wrote the wrong dose of antibiotics for a baby. I made an error of calculation and wrote for 3 times the dose the baby was supposed to get. Luckily, this mistake was caught by the pharmacy. But I wondered, how could I possibly have not noticed that I wrote a dose 3 times what it should have been? Well, I'm human, and I now understand the psychological factors at play that can impede recognizing errors. Having colleagues check you and checking them is key. Let's review. 1. Medical errors are ubiquitous, but can be tricky to define. Errors are preventable. Errors are outcome independent. Not all harm is the result of error. There are errors of decision and execution. Errors range from minor to major. Failure to follow accepted practice standards play a central role. 2. Medical errors come in different flavors. Delayed diagnosis, misdiagnosis, misread imaging tests, erroneous treatment decisions, errors of neglect and omission, errors in execution of procedures, etc. Medical errors are not always about slips of knives or miswritten prescriptions. They are usually not made in isolation by one person. They are often about failures in communication, teamwork, and vigilance. 3. Cognitive biases and blind spots make it harder to recognize our own errors and prevent them. Working in a team where these biases are discussed and where checking each other is encouraged and accepted can help. Anyone on the team has the power to create this culture. As an individual, you too have the power to recognize and minimize medical errors. very tired Leilani Schweitzer was in the hospital with her 20-month-old baby Gabriel. So that she could get a little sleep, a kind nurse turned off the alarms on some of the machines in the room. Thankfully, Leilani drifted off to sleep, but an hour later she awoke to her baby coding. What no one knew was that the nurse had unknowingly turned off all of the alarms, including the ones at the nursing station. When the baby's vital signs dropped, no one noticed. Despite resuscitation attempts, Gabriel did not survive. It was too late. The nurse that made the error never returned to work at the hospital again, and a neurosurgeon involved in the case stopped practicing altogether, an additional outcome that no one wanted. Despite your sincere vigilance, you too will make a medical error at some point in your career, and you'll witness many more. But how you handle those errors can have powerful and long-lasting effects on all those involved. Leilani, who later told her son's tragic story from the TED conference stage, made 3 important points that we should take to heart. First, patients who have suffered from medical errors want honesty and transparency. They don't want lawsuits. Lawsuits are a last resort when they are met with denial, defensiveness, and abandonment. Second, they want a full apology, and for the medical team to stand with them and respond with accountability. They want to see change and to know that what happened to them won't happen again to someone else. Finally, she notes that when a major medical error happens, there are more victims than just the patient. What can you do to ensure that these points are met and to handle a medical error well when it happens? The first lesson is that honesty and transparency is the best policy when it comes to dealing with medical errors. Although only about 10 states legally require disclosure of errors that result in adverse events, there is ethical consensus in favor of honesty. Studies show that what most patients want is for the team to be honest about what happened. As Gabriel's mother said, "We wanted answers, not money." People want lawyers because they feel deceived and abandoned. It's an emotional and expensive last resort that none of us want to do. Patients deserve honesty, and our being truthful and transparent is a way to act with respect and integrity. Surprisingly, being honest actually reduces the chance of a lawsuit. A long-standing disclosure program at the University of Michigan cut the number of malpractice lawsuits in half and saved $2 million in litigation costs in its first year. Being dishonest can increase the chance of a lawsuit, and if you attempt to cover things up, you lose the patient trust. Patients who have medical errors handled poorly are often distrustful of the medical system for the rest of their lives. On the flip side, being honest about an error can actually increase trust. Although we can all agree that transparency is good, there are obstacles that can make it really difficult to actually do. One is not knowing what to say. Another is being asked not to disclose or to cover things up, especially by a senior colleague or hospital administration. And a third point that makes transparency difficult is that laws may restrict exactly what you can say during a legally protected disclosure. Let's work backwards on these points. Did you know that 36 states have so-called apology laws, which protect clinicians from having expressions of sympathy, condolence, or apology used against them in court? Some of those laws only protect expressions of sympathy that something happened, meaning if you admit fault or offer an explanation, then you are open to litigation. This makes being completely honest feel dangerous and communication awkward, like walking onto a minefield. The solution here is not to skirt around the truth or deceive patients or family members during disclosure. Instead, talk with risk management before engaging in a disclosure conversation to practice talking through what you want to say. This can help you craft language that allows for an open and honest conversation while also assessing and preparing for the legal implications. As a physician, I have done this many times and found it to be incredibly helpful. The second thing that can make being honest and transparent about errors difficult is if you encounter a higher-up who berates you, asks you not to disclose the error, or who attempts to cover the error up. There's a great scene from the TV show The Resident where there is a clear error made by an attending who then walks out into the waiting room and lies to the family about what happened. Unfortunately, you may see this and have to deal with it. 62% of residents have observed a colleague being humiliated or verbally abused for an error they made, and 57% have observed a senior team member trying to conceal or shift blame for an error. What can you do if you find yourself in this distressing situation? One extreme is to do whatever you think is necessary, regardless of the existing power structures. Another is to sacrifice your integrity and do nothing. A middle position is to ask those higher up the ladder, including the person who is attempting the cover-up, to explain to you what happened. You can also ask them what they would like for you to say if the family asks what happened. This middle position strategy might gently nudge those who are attempting to cover up to do the right thing. Using a confidential third party, like an ombudsman, is another helpful solution. The final thing that makes being honest and transparent difficult to do is not knowing exactly what to say. Luckily, toolkits exist that can coach you through these conversations. Candor, developed by the Agency for Healthcare Research and Quality, is a great tool and can be found for free on their website. Take the time to watch a few of their videos of good and bad disclosures to gain some tips. I once asked a skilled senior surgeon for lessons learned, and her advice was, own it. Do not blame anyone else on the team. Do not blame the patient's anatomy. She has seen this too many times. Use language that the patient understands. If you don't know the answer to something, admit it, and let the patient know that you will get back to them as things become clearer. Breaking the bad news of an error is very much like breaking bad news about dying. You walk through it with the patient. You update them as the situation becomes clearer. You share your feelings that you too wish this hadn't happened. And of course, you will wish it hadn't happened. You will beat yourself up for it if you are the one who made the error. You will feel shame. You will feel singled out and alone. But you have to engage in meaningful recovery because medical errors can be a major cause of burnout. The key is to talk about it and seek support. Create safe spaces with other colleagues, mentors, family members, and friends. Returning to the opening story of baby Gabriel, his mother poignantly said, "We all should have been given ID bands and became patients that day. Death is a full stop for the patient in the hospital, but is only just a terrible beginning for those left in the room. Only truth and transparency," she said, "can take away the infection of guilt and doubt." Part of the tragedy of that event in her eyes was that Gabriel's nurse and physician never practiced again. Many patients would go without their help and expertise. Being part of a medical error is emotionally difficult, but talking openly about your experiences and feelings can be healing. Let's review. 1. Honesty and transparency is the best approach to dealing with medical error. Patients and families are entitled to know the facts of the situation. 2. If you encounter an attempted error cover-up, ask questions such as what the family should be told. 3. Talk with risk management and use toolkits such as AHRQ's Candor before embarking on the conversation to understand best practices. 4. Patients want someone to take ownership, to apologize, to ensure that changes are made so that the mistake doesn't happen again, to admit unknowns and keep them updated as information becomes clearer, and to stand with them rather than on the defensive. 5. Finding safe spaces to talk after an error is important to prevent burnout. Individuals who make medical errors should not be ostracized, shamed, or blamed, but should be assisted in working through the various issues, including their emotional well-being.